I'm going to touch on some musculoskeletal conditions for two reasons. One, as an exercise specialist, you are going to see a lot of musculoskeletal conditions. You have likely suffered from a musculoskeletal condition. There are many conditions that we could talk about, but I'm just going to focus on two of the most common, which is osteoarthritis and then tendinopathy. Okay, so for a normal joint, and just a quick review, you can see when we look at this hip joint here that there's a joint space in between where we have this nice smooth cartilage. It's very symmetrical, even and smooth. And then we see healthy bone in here. Now with osteoarthritis, there are some characteristics that we'll see. One is there's decreased joint space, and we'll get into the pathophysiology in a minute. It's typically asymmetrical, and I have a better slide that shows this, meaning that you might have more joint space here than over here. We see these exposed bone here, but these are kind of erosions in the cartilage where the cartilage has essentially deteriorated or degenerated. Usually in an uneven pattern. Now the cause of osteoarthritis is going to be one of two things, and then those categories are pretty broad, but excessive or abnormal loading of a healthy joint. And what that means is that the joint is healthy and there's no exposed bone, there's no decreased joint space, it's symmetrical, everything about the joint is healthy. However, there might be excessive, so we think of repetitive stress on an area to an excessive amount, or someone who might be obese, so there's an excess amount of pressure, or an abnormal loading. Now, an abnormal loading might be from a slight malalignment. It could be from a congenital deformity, might be just abnormal biomechanics that someone has always lived with, where perhaps the angle, of the femur is slightly different, so that is going to place excess stress in the joint. It could be from a muscle imbalance too, so again, abnormal loading, so where the muscles are pulling in one direction or another, so that causes, and let's just say maybe more stress up here than down here. So even though the joint is normal, it's getting an abnormal amount of stress in one area because of maybe faulty biomechanics. Now there could be normal loading of a previously injured joint. And so just if someone had a traumatic event and maybe they had an injury to the cartilage or some other part of their joint, just a normal pattern of loading could actually end up causing arthritis to happen at the area where they previously had the injured joint. And then kind of in a combination of these two, if there's some sort of previous injury, let's say an ankle fracture or something, the joint could be slightly malaligned, say after surgery. That will then put on this kind of normal loading. So it's almost like a little bit of a combination of those two. Now the pathophysiology, this is what's happening, what is the normal physiology? Now we're talking about what is happening in this disease process that's abnormal. When there is some sort of abnormal loading or excessive loading, some sort of injury that does occur, the chondrocytes, which are the cartilage cells, are going to try and repair. But what happens is it ends up increasing the proteoglycans. Proteoglycans are proteins with usually with a glycosaminoglycan attached. Basically, it's the cartilage, the part of the cartilage that resists the compressive load. So if you can imagine it just being kind of squished down and then it kind of expands back up again, has that elastic component. So it kind of increases the proteoglycans, increased cytokines, inflammatory cytokines. So this is where we have this inflammatory component. Now, as the condition progresses and it's more advanced, this is where the cartilage starts to lose its elasticity, and we actually start losing the cartilage. So this is, if I were to jump back up to this one, we start getting these clefts or erosions within the cartilage. It might start showing some exposed bone under the cartilage, and this is where we get this asymmetric joint space loss. The head of the femur here, we have this nice kind of smooth surface, and then as we come around to here, you can see it's a little bit flattened. And see how much space is in between here, and now all of a sudden we've lost that joint space. This right here is called subchondral sclerosis, and this is a subchondral cyst, so subchondral, kind of below where your cartilage is. These are classic signs on X-ray of arthritis. So when people talk about, oh, it's bone on bone, I mean, you can really see how there is no space in here. There's very little synovial fluid. The cartilage has kind of lost its elasticity and its ability to kind of compress and rebound. So it's just compressed down, and then you have the loss of joint cartilage as well. The symmetrical part is important. And, I didn't mention this earlier, but there are lots of types of arthritis. And say rheumatoid arthritis, which is an autoimmune joint disease, has a very different pattern and a very different pathophysiology than osteoarthritis. And that's why it's very characteristic of osteoarthritis to have this asymmetrical pattern of joint space narrowing, these subchondral cysts. Let's move on to tendinopathy. Tendinopathy is kind of this catch-all term for tendinitis, tendinosis, peritendinitis, all these different tendon pathologies. I'm just going to talk about the itis and the osis. I want to make sure you know the difference between those two. Itis means inflammation. Osis is more deterioration. If you go to the doctor and you have tendinosis, it's possible that not an orthopedist, but your general practitioner is probably going to diagnose you with a tendinitis. And it's just they're commonly flip-flopped, or tendinitis is commonly used to describe tendinosis, but they actually are different conditions. Tendinitis does start with microscopic tears. This leads to inflammation. There is some disorganization of the collagen fibers, but it tends to heal more quickly. Tendinosis, and this is important, it's non-inflammatory. It's a degeneration of the fibers, the tendon fibers, which is a deterioration. It is classically described as this disorganization of the fibers. So you can see they're nice in this nice alignment. Now here there's some disruption. There's some disorganization of these fibers, and tendinosis tends to be more chronic. For both tendinitis and tendinosis, it's, same thing we talked about, this repetitive overloading, this excessive stress. And the one thing that's a little bit interesting about tendons is they can have a chemical cause, and this is mainly due to the fluoroquinolones. You're probably familiar with Cipro, but they actually can harm the tenocyte. So if there is any injury, there is no repair process that happens, or it doesn't happen fast enough. So if you can think about an athlete that's, already having this repetitive stress, and then maybe they're prescribed Cipro, they have a much higher chance of having some sort of tendon injury. So just for tendinosis, this slide here on the left is a normal tendon, and you can see how organized these fibers are. I mean, look how beautiful this is, just nice in alignment. And if you could think about, a rope, and how all of the fibers in a rope are in this aligned, they're parallel, and then they usually get, twisted and wrapped together, and it's super strong. But now let's look at this. This is just a mess, right? I mean, where are the tendon fibers? This is tendinosis. This is what it looks like. I'm going to talk a little bit about the hypercellularity, vascularity that occurs in tendinosis. but also this disorganization. Look how disorganized this is. So think about that rope again. If you took all those individual fibers from a rope and then you just laid them all down in just some random order, would that rope be strong? No, it wouldn't be strong at all. So that's essentially what happens with the tendinosis. So we have tendon degeneration, disorganization. It's non-inflammatory. We have a neovascularization, so these new blood cells got to grow into the tendon, but it's very disorganized. And the tenocytes actually differentiate into different cells, so they're not even active, and then they proliferate. So we have all these extra cells, but they're not really helping the healing process. So ultimately, we have impaired healing. Like the tendon is just stuck in this impaired healing, and that's why this is so chronic. It can go on for months. When I was practicing podiatrist, we saw Achilles tendonitis, tendinosis all the time, posterior tibial tendinosis all the time, and it's a year, not uncommon, year and a half, sometimes even 2 years. So it's a very chronic problem because we have the loss of the cells that we need to actually help with the repair process. And the whole reason I'm covering these conditions in this section is just because the first line of treatment is NSAIDs. Now, NSAIDs are non-steroidal anti-inflammatory medications, and we just learned that tendinosis does not have an inflammatory component. NSAIDs are still really commonly prescribed because they also will inhibit pain. So they do have this symptomatic relief, but they actually can inhibit the healing process. I mean, we need that inflammatory process at some level to actually generate the healing, and we don't have it. So NSAIDs can be counterproductive, but I'll tell you, if you went to your general practitioner, or even your orthopedist, you might get anti-inflammatory medications. That wouldn't be uncommon. It's still part of the standard of care in a lot of ways. Same thing, we talked about steroid injections, steroids last week. We know that inhibits, that top part of that inflammatory cascade. And they're commonly used to treat arthritis, not so much tendonitis, but sometimes with tendinosis. It really depends on the location. They're never injected in the Achilles tendon for tendinosis, and nor are they injected for like posterior tibial tendinosis. But there are other areas of the body that don't take up as much stress, or they're not as at risk for, say, rupture. And so they might actually be used. So I know this is a little bit complicated. We always think of anti-inflammatories to treat inflammation, but they are sometimes used for tendinosis, but it's super controversial. So, but I'm not expecting you to know all of these here. I just I just listed it. Okay, well, that's it for this section on musculoskeletal conditions.